Let's switch to ASCO now.
ASCO.
There was actually AUA very briefly, and there was a lot. We had a really good discussion with the AUA chairman,
Dave Penson,
yeah,
Secretary.
and he talked a lot about non-muscle invasive bladder cancer and the progress being made there. I think we're going to save the Sunrise discussion and that for a little bit later because there was fabulous data at ESMO in there. Yeah. But I think that AUA podcast around it, because he talked about other therapies intracycle as well. Yep. He talked about immune therapy, immune therapy IV pembrolizumab, and the other studies that are coming out. We're looking forward to. We haven't seen them yet, but we've got other randomized phase 3 non-muscle invasive studies with PD-1 inhibitors. He talked about some of the intracycle gene therapies, and he also, of course, talked a little bit about the Sunrise program. Let's go, though, to ASCO and start with, let's go with KIM1, and let's go with biomarkers for kidney cancer.
I thought you'd never ask.
I actually think that was the best biomarker data, best session for biomarkers we've ever seen, because we saw I
don't disagree.
We saw axi-pembro, which had RNA-seq, mutational analysis, protein analysis. Yep. We saw len-pen with exactly the same, and we saw the KIM1 data for atezolizumab. Do you want to summarize where we are with
all
those?
Of that?
Yes, please.
So KIM1, kidney injury molecule 1, has been around forever, part of the TIM family. As the name implies, it's a molecule released with kidney injury. It's been used in the nephrology space for, I think, decades. Right, about interstitial nephritis and other disease. And it turns out there's an analysis from Emotion O&O. Laurence presented these data, baseline KIM1 and then also post-treatment KIM1. Focusing on the baseline results, baseline KIM1 was prognostic, i.e. a high KIM1 portends a worse survival. And as I've said before, I kind of think of this as sort of the ctDNA of kidney cancer, right? Whether that's true or not, we can debate. But high KIM1 associated with worse outcome regardless of treatment. And then if you look at the within arm, it's predictive for response to atezolizumab. So high KIM1 does better from a DFS standpoint on atezolizumab and worse on a placebo, right? Because it's prognostic. And so again, early data, we've seen it from 2 other trials, Assure, the TKI trial that Naomi Haas did, and then Checkmate 914, the adjuvant Ipi-Nivo, which showed really the same thing. They looked at quartiles. The KIM1 data at ASCO looked at a median cutoff. It wasn't the median, it was actually at 60%. So these are all sort of initial data sets that need prospective validation, but the signal is consistent throughout. It's prognostic and seems to be predictive for single agent immune therapy in this setting. And we talked about giving adjuvant pembro and this and that. We could really use a biomarker in this setting because there's still a lot of uncomfort of, I'm just going to give this to everybody, knowing that maybe half the patients don't have cancer and you can't possibly help them. So I agree, I thought that was exciting data. There's some prospective work planned. I think we'll look at it in neoadjuvant. I think that it opens up a whole new world of biomarkers in kidney cancer, which, as you say, has been a long time coming. Focusing now on the metastatic setting, there was axi-pembro 426 and the len-pembro clear trial. And Tony and I presented sort of similar data sets, as you might imagine. Looked at RNA-seq. We looked at this T-cell GEP, which Merck has analyzed and published.
T effector signature, essentially immune activation. It's an interferon gamma signature.
It's an immune activation signature is how I think of it. It's been shown sort of across their Pembro program.
Also the Atezo program.
Yep.
That work that the atezolizumab folks did first with Emotion 150 and 151 really did set the scene with, I think.
I think so. You and I are both involved and I have some biases, but our friend Dave McDermott published the Emotion 150 years ago now. And again, all these signatures from different companies and different trials, they're not identical, but they're all kind of getting at the same biology, right? There's an inflamed biology of tumors. There's an angiogenic biology, at least in kidney tumors. 426 showed that T-cell GEP was associated with the clinical outcomes response, PFS and OS in the axi-pembro arm, not in the sunitinib arm. Now, that wasn't shown in the len-pembro data. That was the one sort of discrepancy that I have a little bit of a hard time reconciling. And it may just be different TKI, different length of follow-up. I'm not quite sure that I understand that.
Or it might just be, ain't that great?
It might be that it's not that great. I hadn't thought of that. One of the things that all these analyses have shown is that there's a pretty strong angiogenesis signature that predicts response to, in this case, sunitinib. So we've been looking for biomarkers for sunitinib for 20 years.
And we found them.
And we found them now that we don't use the drug anymore.
I think c-MYC mutation as well, bizarrely, came through on all of them.
There was this sort of proliferative signature, either DNA or RNA, and it kind of, and those are probably, we talk about immune biology and angiogenic biology in kidney cancer. There's a whole nother biology. From the 151, it'd be like cluster 3 and 6, or MYC. there's this whole other biology that we're totally missing.
And actually the biomarkers for sunitinib seem easier than the biomarkers for the PD-1.
I think they're more straightforward.
VEGF
and whether we can integrate those, say, into second line where we're giving single agent TKI or wherever, I don't know that there's a lot of motivation to do that.
If you travel back in time, Bob...
Which I do often, yes.
Bob Motzer and others, it's not that difficult actually. Bob Motzer and others looked at the biomarkers program associated with Ipi-Nivo in a similar way.
Yep.
And actually that was, because you might think, okay, it's all contamination because the VEGF TKI, PD-1 makes any biomarker pretty difficult when you're going against another VEGF TKI because you haven't got that third single agent immune therapy arm. But when you look at Ipi-Nivo versus sunitinib and you look at those biomarkers, you know, the angiogenic signature, bizarrely, Ipi-Nivo does quite well in that group of patients. And that may be, you know, that may be for lots of different reasons, but the way I looked at those RNA signatures overall is we did a huge amount of work, incredibly robust analysis. I think a brilliant series of scientists working for the drug companies actually. My take on it is it hasn't taken us that far forwards.
I don't think it's taken us to a clinical utility where I see a patient, you know, tomorrow and I say, oh, I'm going to send your tissue for RNA-seq right outside of a trial.
And mutational analysis and PD-L1
the DNA's been, I think biomarkers in kidney cancer are RNA-based, not DNA-based. The DNA mutations...
Can we put the tumours behind us now and just say, look, we've done the best we can, we need to move to circulating biomarkers and now focus on a new chapter? Are we there?
I'm not ready to do that.
Is there still work to do on the tissue?
I think there's work to do on the tissue. You know, we're doing a prospective study called OPTIC based on, you know, RNA-seq on, well, now we've mandated now metastatic tissue because there's a difference, you know, in site of tissue origin and the cluster assignment or other RNA-seq data. So the ASCO data was important, both KIM-1 and these analyses we just talked about. I agree, it hasn't taken us to clinical utility, but we're a whole lot better than we were a year ago or certainly 5 years ago. And there's going to be another breakthrough. I'm just not sure where it is.
At the Uromigos Cup, a couple of months ago, Chris Sweeney, who wasn't able to be there because he was in Australia, sent a questioner, one of the questions in, and he talked about how brilliant Australia was at sport, which I think is true, by the way. Never take on Australia at sport. As far as if I give anyone any advice, that would be the case. However, his question was about Charted-2, which was presented at ASCO. And Charted-2 looked at a different question. It wasn't Charted-1, it wasn't first line, it was second line. It looked at cabazitaxel plus Abi versus Abi, and it showed a PFS but not an OS advantage. There was a question at the time about you know, how applicable this currently was, because clearly the first line standard, lots of patients are getting Abi first line or Enza first line. But it was you know, I guess it did reinforce the role of chemotherapy in this disease.
I'd say a couple things. Number one, Christos Kyriakopoulos presented it, former fellow of mine at Cleveland Clinic, great guy. And again, we've talked about this in so many settings. When you're designing these trials today, especially cooperative group investigator initiated that take a long time, by the time you get to the readout, sometimes the field's passed you by, you know, and it doesn't mean it wasn't a good question or a good trial. It just means, well, things change and most people are getting Abi or some ARPI up front. So now you're talking about, you know, Abi plus minus Cabeza, just not a relevant clinical question, as I think the investigators admitted. You know, I think had they shown an OS advantage or something, well, we're having a different conversation. Cabazitaxel is an active drug in prostate cancer, right? We use it clinically, and so I think it maybe reinforced that role. You know, even though chemo sort of has this, patients don't want chemo, we don't want to give it in prostate cancer. Both taxanes, you know, Taxotere and cabazitaxel have activity. So again, good cooperative group effort. Showed this PFS advantage, didn't show OS. So I don't think it impacts practice, but I think it's important data.
There was some bladder cancer data at ASCO too. There was some data from chemo, gemcitabine, looking at the lymph node subset and the CR group, and they found a group of patients that do really well. I think when you do that, you know, inevitably lymph node patients are going to do well, but their CR rate was really high. The way I took that overall is that bladder cancer has, you know, the broad spectrum, and some patients do well. If you look at the lymph node only population with the Kaplan markers with EV Pembro, that looks pretty good too. I don't think personally we need to be fishing around for the right group to not to give EV Pembro to. I think actually EV Pembro has superseded platinum-based chemotherapy in unselected patients, except for those patients who can't have it. We saw Shilpa did a lovely presentation on the quality of life of EV Pembro. And I think that we'll probably talk a little bit more about that in a second, but from what I saw on that is those patients who were symptomatic at baseline, had pain at baseline, the EV Pembro seems to be good at controlling that. We saw in 301 as well.
I'll just say, let me comment on the lymph node analysis that was ASCO?
Yes.
Lymph node only patients, correct me if I'm wrong, in bladder cancer have always done better, right? That's even to just GemCis or MVAC or whatever, they've always been a population of patients that can be cured with chemo alone, right? Yes. So that's a biology,
And we know that from the adjuvant, when you do adjuvant surgery and you have a little lymph node positive, I don't think surgery gets rid of all of your lymph nodes.
Right.
I think you've got MRD if you're lymph node positive, and surgery's not going to change you from MRD negative to MRD positive to negative.
I think it's important. I think it'd be most important, that data, for if I'm sitting with a patient in clinic and saying, gee, you have lymph node only disease, you're likely to do really well, right? Because those are the questions you get every day. Hey doc, how am I going to do, right? That's a prognostic question.
And in those parts of the world that don't have access to EV Pembro,
sure,
which is still the case today.
Yeah.
If that was where that, and in fact the majority of the world I suspect today, but that will be different I hope this time next year. But the reality is for those patients who don't have that, and the discussion about chemotherapy and maintenance of avelumab or GemCis Nivo, I can see why it comes back to that principle about giving that immune therapy, giving that PD-1 a bit earlier.
Yeah.
Why keep it in the locker with the uncertainty about whether you can give it? So I think that actually reinforced a little bit that balance between the role of immune therapy and chemotherapy together. And it debunks some of that myth, which obviously happened earlier in the year, in years gone by, around chemotherapy and PD-1 therapy being antagonistic, additive, or synergistic. I think it's partially antagonistic. I still feel that way. But there is some positive effect between the two in that cisplatin subgroup. That, of course, where Matt again beat me in that debate, which is still very upsetting. If we move on from there was a bit more data and I think now is a good time to talk about sacituzumab govitecan, if we can, because there was the SURE-1 data, but there was also the TROPiCS-4 press release. They both happened at ESMO and ASCO. And TROPiCS-4 is sacituzumab govitecan versus docetaxel, paclitaxel in patients who's previously had chemotherapy and PD-1 therapy or PD-L1 therapy. And we know that trial is negative. The EV301 study with enfortumab vedotin, very similar design, was positive for PFS. And actually, when you go back in trial time, docetaxel plus ramucirumab, do you remember that trial? That had a positive PFS but no OS. So it's an environment where most people feel you should be able to win.
Right. Second line chemo in bladder has never been a good thing, right? It's never been.
And I think in the press release there was an issue around the toxicity signal. And
we haven't seen the data yet, but I personally don't think it's, there was so much upfront toxicity and that's why it didn't show an advantage. If you look at, say, SG versus EG, you do see lower response rates, right? You see a notch down in activity, and in order for a single arm activity to translate into a randomized setting, you need enough activity, right, to state the obvious. So it's not that it's not an active drug, but it just wasn't active enough. And I think, the fate of that drug, frankly, I think is really uncertain. Again, we need to see the data. There's data in other settings, but I think it created this. I was surprised at the results a little bit, but maybe not sort of looking at the phase 2.
And of course, the FDA has now withdrawn its label. And so that changes things in the United States of America.
Yep.
And at our Uromigos meeting, there was lots of positivity around the drug. I think it is active, and I think some patients do well with it. But the rules that we play by is you need to have positive randomized trials. If you get accelerated approval, you have to translate that.
Right.
And
I think that's fair.
Oh, I agree.
Because there's, as we talked about at our meeting, there's a lot of ADCs out there that have high levels of activity, and then you add in PD-1, it goes to 70, 80%. So even if it's active, if it's on the bottom of the list of active drugs, I'm not sure we need it.
So had the design been slightly different to the trial, I suspect the trial would have been positive. There are ways in which sacituzumab can beat. It's active here, but you play by the rules to some extent. There was also some SURE-1 data, neoadjuvant 4 cycles of sacituzumab govitecan, and I think that gave us a bit of an indicator, a clue to the future. And that clue to the future was that a lot of patients at the end of that trial had clinical CR, and they didn't have surgery. It's very hard to interpret that data because you can't really do your past CR rate if half the patients don't have surgery. And so we don't really know very much about where we are with that, which I think is complicated. But I think it brought us on because at the same meeting there was some data with toripalimab and disitamab vedotin with a past CR rate of 61%. And we're beginning to get an indication that in the neoadjuvant setting, EV-Pembro may do the same thing, if all things being equal. And I felt that was, for me, that was really important information. I think that draws a line under ASCO and the first half of the year.